Okay, everybody, our next special population is pregnancy. I'm going to use this patient population as a good place to kind of review and integrate some of our cardiovascular knowledge, as they have a really unique functioning of their cardiovascular system when they're supporting the life of the baby. And then later on in the lecture, we'll use this as a place to introduce the respiratory response to exercise, as this patient population has some issues there too. So let's start with our case. Sarah's coming to physical therapy for hip pain. She would also like advice on incorporating aerobic exercise into her routine. So the first question that you have to ask yourself is exercise safe for a patient who is pregnant? And previous medical advice would have said decrease exercise during your pregnancy. The concerns are that they were very concerned about increasing body temperature. We'll talk about this more and later actually in this lecture, but when you exercise, you create metabolic heat and your body temperature does go up when you're exercising. They didn't know what this would do to a baby, so they were fearful of this heat element. There was concerns that you would reduce the amount of oxygen going to the baby, right? There's this vasoconstriction everywhere and you get local dilation in your working exercise muscles. Could that in some way deplete the baby of oxygen? They were worried that there would be decreased fetal size. They were worried you could cause injury to the mom, that the patient herself, musculoskeletal, she could fall, could she damage her placenta in some way that would impact the baby. So for years and years, they told women not to exercise when they were pregnant. There has been a lot of research on this now. And what we've seen is that when women exercise, there is no evidence of an early pregnancy loss. So it's not inducing labor or causing an early delivery or a loss of baby early on in the pregnancy. There is no evidence that it causes late pregnancy complications. So it's not inducing any of the things like preeclampsia or some of these other negative things that can happen late in your pregnancy. Exercise is not related to that. There's no evidence that babies who are born of women who exercise have any abnormal fetal growth or adverse neonatal outcomes. So the reason this was such a tricky question is this is not an easy group to do research on. So they really had to kind of watch and see what happened with women who were exercising. And more when they were seeing these pregnancies were fine, the births were fine, and the babies were healthy and normal, we've gotten the confidence to say it is safe to exercise. So the understanding now is that previous recommendations had been overly conservative because of a lack of evidence, because there weren't studies being done, and they erred on the side of being conservative to protect the baby. The problem with the conservative approach is that inactivity actually carries its own set of risks. And this is something that we need to be talking to our patients about in many different patient populations. You know, in our last lecture, we were talking about how patients with arthritis, the greatest impediment to exercise is a fear you're going to make the joint worse. But not exercising actually makes the joint worse. And exercising decreases pain, improves quality of life, all the things we said in our last lecture. So this conservative approach is interesting because not doing something isn't the same as eliminating risk. So if a woman is pregnant and she participates in no activity, she has an increased risk of gestational diabetes. That is a elevation in blood sugar caused by the pregnancy. And gestational diabetes brings on a lot of risks for the baby and the mom. Women who have gestational diabetes have babies that have a much higher birth rate. The mom, after having gestational diabetes, will have an increased lifelong risk of getting type 2 diabetes. If you are inactive during your pregnancy, there's a reduction in your cardiovascular fitness, a reduction in your skeletal muscle fitness. There's also an increase in weight gain for those pregnant women who do not participate in activity. There's an increased risk of a deep vein thrombosis and increased risk of varicose veins, larger amounts of hypertension in inactive patients, worse dyspnea, low back pain, and psychological and emotional deficits as well, or issues as well. So the conservative approach is not just, being kind to women or being overly protective. It actually is bringing on a new list of risks. And the benefits of exercise are very long. I'll read these through kind of quickly, but they kind of go into our what we already know about exercise, right? If you're exercising regularly, you can prevent excessive weight gain during your pregnancy. You can prevent gestational diabetes. You actually have a decreased risk of preeclampsia. Preeclampsia is a very severe form of hypertension that can come during the pregnancy. Decreased incidence and symptoms of low back pain. So if you remember that one of the main things they were worried about with women exercising is that they were going to get hurt because of some of the musculoskeletal issues related to pregnancy that we'll talk about in this lecture. But in fact, exercises decreases their low back pain, which is one of the most common musculoskeletal complaints of pregnant women. Decreased risk of urinary incontinence. Oh, this is such a great topic, and we're going to have a whole lecture on women's health. But the coordination of your pelvic floor and your core musculature and the relationship between the activation of those two during exercise is so important for pregnant women. Their pelvic floor health is really, really important, and exercise is actually going to help strengthen pelvic floor. Prevention and improve depressive symptoms. They can maintain their fitness during therapy, and it can prevent some of the postpartum weight retention that a lot of women battle with exercise, or battle with pregnancy, excuse me. Let's go to the top of the next page. I just want to touch on the trimesters of pregnancy, because we use that term, you're pregnant, as like a static condition, but it's not a static condition. The body is constantly changing over the course of the pregnancy. We kind of arbitrarily lump it into trimesters, but obviously there will be some variability between people. But in general, when a woman is in her first trimester, the greatest impediment to being able to exercise is fatigue. There's extreme fatigue in the first trimester. And the reason for this is in the first trimester, the woman is building the placenta. And that takes an incredible amount of metabolic reserves for her body. She's basically building a brand new organ to support the baby. So if you're treating someone in the first trimester, they might not tolerate exercise because of fatigue. So if you're going to prescribe exercise, it might be more effective if you kind of spread it out throughout the day, or you decrease the work to rest ratio, kind of prescribing it in the context of fatigue. The other big thing that happens frequently in the first trimester is that women experience a lot of nausea and vomiting. And while this might impact their ability to want to do exercise because they feel cruddy, it also affects their caloric intake. And remember, they're building a placenta right now, so they really have a high caloric need. And if they're not able to keep their food down, it might not be appropriate to add exercise. So talking about their frequency of vomiting and how well they're eating and the nutritional aspect is an important thing to keep in mind if you're prescribing exercise in the first trimester. In the second trimester is really when the baby starts to grow. So this is the semester where there's a lot of weight gain. As it says in your notes, about 3 to 4 pounds per month, obviously give or take. In total, it is considered normal to gain somewhere between 15 and 35 pounds throughout the course of your entire pregnancy. Weight gain is something that is needed and beneficial, and many times it gets too high, right? It gets beyond that 35 pounds. And exercise is a really key element for weight control during this time of massive growth. In general, women are recommended to increase their diet to add an additional 300 kilocalories per day during this time to support the growth of the baby. So depending on your role and what you're doing with this patient, this might be something that you're really involved in regulating weight and kind of keeping track. of what they're doing. Or you might just be prescribing exercise for a different reason, and this might come up in conversation. But it's important to know that it's normal and healthy, but be, outside of, higher than the 35 pounds, you're starting to give yourself risks of things like gestational diabetes, and it's just going to put a worse load on your musculoskeletal system. So one of the big things that happens in the second trimester that comes along with the weight gain is we have increased strain on joints and soft tissue. So one reason for this is the rapid weight gain. And the rapid is really key in that sentence. There's no time for adaptations. So, in a typical like Western diet where someone becomes overweight and obese, that happens very slowly over time. And actually their musculoskeletal system kind of accounts for it as they go. It's kind of like Milo and the calf, right? Like just slowly increasing the load on their musculoskeletal system, they adapt. When a woman is pregnant, the changes happen really quickly. First, breast tissue gets dramatically larger and heavier. And if they're not using proper support for the breast tissue, they can have a lot of thoracic and upper back pain, postural changes from the increased load on the anterior side. And then obviously the baby growing in the abdomen area also causes this problem. So keep in mind, I see a similar thing. I saw a similar thing a lot in my teenage girls when their breast tissue would come in. If their breasts grew in very suddenly and they were very well endowed, a lot of upper back thoracic pain because those muscles just, they can't keep up with how fast the weight is changing, on the other side of the body. So just kind of keep in mind when there's a rapid change in the body, there's less time for the musculoskeletal system to adapt. So the musculoskeletal issues are confounded by the fact that during your pregnancy, there is connective tissue laxity. And that is because of a hormone that is produced by the placenta called relaxin. And relaxin stimulates this increased laxity of your connective tissue, which is critical to allow your body to adjust and change and ultimately be able to birth the baby, because you need all the ligamentous support of the pelvis to become more stretchy and loose, the baby can come out. But because of that, because there's laxity now in all the connective tissues that we're helping to stabilize, and this is especially true in the lower back and the pelvis, we see increased pressure on the pelvic floor, and it's very typical for this hyperlordosis to occur because there's this huge anterior load and lack of passive support, sudden change in the weight, and you get this kind of low back issue. So as this slide shows, there is supportive devices that can help support the back and support the weight of the baby, and they can make a huge impact if someone is suffering because they just might not have the time to get the strength training, for their back to support the baby. They might just need the external support. In the same line, this strain on joints and soft tissue comes this idea of diastasis recti, and that is a separation of the abdominals, and it's due to stretching and thinning of the linea alba. So you are considered to be positive for diastasis recti if your separation is greater than 2.7 centimeters right at the umbilicus. So that's how it's measured. When somebody has pathological diastasis recti, this is going to weaken the function of the abdominal muscles. It's going to decrease the ability to support posture, trunk and pelvis stability, its role in respiration, trunk movement, support of abdominal viscera. So women who suffer from diastasis recti are going to be left with a lumbar spine in the pelvis that's more vulnerable to injury because they're going to have lost this anterior support. The patients who are more likely to experience diastasis recti is when they have older maternal age. I will try to keep my personal stories out of this, but I have a significant diastasis recti, and I was an old mom when I had my babies. So this one always is a bitter pill to swallow and say out loud, but you increase your risk with older maternal age. Although I still highly recommend waiting until you're with the right person and your life is ready for a child. It's worth the diastasis recti, I promise. Okay, increased risk if the baby is larger. So this kind of, you start to see compounding elements here. So women who don't exercise are more likely to get gestational diabetes. Gestational diabetes is more likely to cause high birth weight. High birth weight is an increased risk factor for diastasis recti, which can then leave these women with pathological weakness in their core following the pregnancy. Another increased risk is multiple pregnancies. I'll check that box too. And then obviously multiple babies at one time. So these are the things that increase your risk. All women who get pregnant have some degree of risk for diastasis recti because of the elements we already talked about. So all women should be thinking preventative for diastasis recti, and all women who are pregnant should avoid aggressive abdominal exercises once they're basically past the first trimester, once they're past 12 weeks. The big one is no crunches. So the reason for this is the effect that it has on the abdominals. And while the motion of doing a crunch is so much pulling on the linea alba, it doesn't mean that you don't want to do core exercises. You still want to maintain a strong core. You just don't want to be doing the big forward crunches that pull on the linea alba. So doing a lot of transverse abdominis activation. TA actually has strong fascial links to the rectus abdominum and the linea alba. So the TA can actually draw the bellies of the rectus abdominis together and help to improve the integrity of the linea alba. So it's not that all core activation is bad. It's this really aggressive, sit-ups type activity that's more going to pull away, where core activation, stabilization of the trunk, and then challenging that core is a better option for patients. So the stronger the abdominal muscles, the less stress on the linea alba. So exercises that have been shown to prevent doing core contraction and sitting, laying flat and lifting their head up is a way to safely activate your core. Squatting against the wall, squatting with a ball between their knees are all exercises that have been shown in research to help reduce the incidence of diastasis recti. Oh, and there we have the slide. I like this picture because you can really see, obviously, woman is post her pregnancy, but you can visibly see the separation of her abdominals and the diastasis recti that was left behind. So still in the second trimester, this is the big baby growth trimester, you still have a lot of postural changes as the load increases. At this point, women start to experience leg cramping, can be a common complaint. A lot of leg cramping is from dehydration. During the pregnancy, you need to really increase your water intake. You also feel like you have to go to the bathroom all the time. So a lot of women don't drink as much, especially if they're working, because they don't have the ability to go to the bathroom frequently. So it's important to talk to women about being really well hydrated. It can also be if they're doing jobs or in their life, if they're doing prolonged standing, they can get blood pooling in their legs that can actually lead to some cramping. So just talking about activity and keeping moving, taking sitting breaks can be important. One big one for PTs is once they're about midway through their second trimester, you need to avoid the supine position. And the reason for this, as you can see in the picture, so if you focus here on this picture, when you're laying on your back, you have your spine obviously here, and the vena cava runs between the spine and the baby. When the baby gets to a certain weight, when you lay on your back, it actually occludes the vena cava, which would obstruct venous return and reduce cardiac output. Now, it is not life or death. If you have someone lay on their back for a minute, they typically would notice and feel it. But in a therapy setting, they might not speak up or try to change positions like they would in bed. So you just want to be aware of the load and what you're doing to the body. So you just don't do any activity in supine. You can do side lying, you can do like a modified prone, like a tabletop type thing, but no supine activity. I feel like normally if we were in person in class, someone normally raises their hand around here because this feels very difficult to manage, I think. And the question normally comes up like, what do you do when you sleep? And once you get to this point, you really are not comfortable sleeping on your back because of this. So it would wake you up and you would roll over if you end up on your back. It's just your body gets a sensation that it's uncomfortable and you'd get off of it. But in general, women are not sleeping on their back once they get to that mid-trimester point. All right, so first trimester, super fatigue, building a placenta. Second trimester, major baby growth. Third trimester is kind of like you've already baked the cake and now it's just cooking in the oven for a while. So still weight gain. At this point, the baby's just getting a lot larger. So things to consider, this is when the fatigue comes back. Sometimes people refer to the second trimester as like the honeymoon phase of the pregnancy because you're not as tired. First trimester has a ton of fatigue, and then third trimester, you're just carrying around a much higher load and that fatigue comes back. This is the trimester when women really start to become uncomfortable because the size and the position of the baby and the musculoskeletal issues we've already talked about have now just become exaggerated as they go on. Dyspnea becomes more common, and I'll just kind of mention that here. We're going to go into a whole discussion of the dyspnea related to pregnancy, but obviously there is a baby taking up the space of where your diaphragm normally descends, and that will affect your breathing. I want to put on your radar, point number 4 under third trimester is Braxton Hicks contractions. This is a type of pain-free contraction that's very common in the third trimester. And I always think of it as kind of like the body's getting ready for birth, but these are not pre-labor or labor contractions. Contractions that are associated with labor are very painful. Braxton Hicks are pain-free, but you will likely, if you're treating women at this time in their pregnancy, that they will experience a Braxton Hicks during therapy session. It's perfectly normal. The belly gets really hard, almost like a rock hard outside as the whole muscle contracts. It doesn't hurt. It doesn't do anything to the baby. It's not a sign that you're pushing them towards pre-labor or anything like that. It's a completely normal part of the third trimester. Heartburn and edema are both going to be big factors in the third trimester. I just wanted them in the list here. We're actually going to talk about the how and the why later in the lecture. And then weight gain continues. So those are kind of the nuts and bolts of the 3 trimesters. So it is really important to know where they are in the spectrum when it comes to prescribing exercise. So while your body is creating a whole nother body, this is obviously going to make some changes to your cardiovascular system, since this is the pump that delivers all the blood, carrying all the oxygen to the metabolically active parts of your body. So when you are going through your pregnancy, you can increase cardiac output by about 40 to 50% at rest. So resting cardiac output can be 40 to 50% greater than before you were pregnant. This should somewhat make sense as your size has gotten a lot bigger and you're supporting a lot of metabolic activity even at rest compared to someone who is not pregnant. But let's just separate that out a little bit because we know about cardiac output and it's important to understand what's going on in our patients' bodies when we're treating them. So cardiac output is heart rate times stroke volume. So these are the 2 things we have to play with. Let's first talk about heart rate. So when someone is pregnant, you do expect a higher resting heart rate. As it says in your notes, heart rate increases at rest by about 15 to 20 beats per minute above what this woman's normal resting heart rate would be. So you kind of expect a typical resting heart rate in a pregnant woman to be between 80 and 90 beats per minute. On average. Obviously, people fall above and below that spectrum. But it's always really important to know your expected abnormal findings and normal findings. So you should expect a higher resting heart rate. And then what happens during exercise? So there's been a lot of debate on what is an appropriate heart rate response while pregnant. And I like this chart. This is a collection of recommendations from some of the main governing bodies, but it really takes into account the woman's fitness level, which a lot of the earlier recommendations didn't, and they were way overly conservative. So for a number of years, I've had to give this lecture, and I had to provide these heart rates that were so low. Students would always be like, well, how can you actually exercise them when they're that low? But the new recommendations do take into account fitness level and BMI, which is really important in terms of risk. So, and age, always that maternal age. So if we start in this like 20 to 29-year-old range. If you're less than 20, you don't have the exercise limitation. But 20 to 29, depending on your fitness level, you can tolerate more of a heart rate, which really fits with the clinical recommendations that what was actually happening. A lot of clinicians would tell women, if you were doing it before your pregnancy, it's relatively, it's safe to do it now as long as you're listening to your body's feedback, of course. But if they're fit, they can get heart rates between 145 and 160. As they get older, those recommendations are going to go down a little bit, become a little more conservative. And if they have a BMI greater than 25, it's going to be a much more conservative recommendation. So take that with a grain of salt, but every woman is different, and it's important to look at the whole picture, but these are kind of the recommended heart rate recommendations. And then that being said, heart rate isn't super reliable as an indicator for intensity. So a lot of people prefer using a rating of perceived exertion scale. If you're using a 6 to 20 scale, a Borg RPE somewhere between 12 and 14 is typically considered appropriate for women when they're pregnant. All right, so heart rate does increase with pregnancy. It increases at rest, which would help to account for some of the increase in cardiac output. All right, so what about stroke volume during pregnancy? When a woman is carrying a child, she has a 40% increase in blood volume. 40%. She's like a blood-making machine during this time, and a baby-making machine, but that's secondary to this conversation. What does a 40% increase in blood volume do for her cardiovascular system? Specifically, how does an increased blood volume relate to stroke volume? Does this have any effect? Hopefully, what jumping into your mind is something about preload. If you are increasing the total blood volume, that is going to increase preload. If you increase the blood that gets into the heart by the end of diastole, you're going to pump more blood out. Simply because more in equals more out, and you're going to activate the Frank-Starling mechanism. So I like this picture because these are like classic pudgy pregnant lady ankles, which is a standard. As I mentioned earlier, edema is very common, and it's more common in the later trimesters, especially when this blood volume gets so high. So how would an increased blood volume contribute to edema? I think this might be the first time this semester. I'm excited. Do you guys know what I'm referring to when I start talking about edema and increased blood volume? Are you having any nightmarish flashbacks to Starling's forces from Panovis? Yes, if you increase blood volume, what are you going to do to Starling's forces? You are going to increase capillary hydrostatic pressure, which is going to facilitate fluid leaking out. Anytime I can talk about Starling's forces is a good day for me. I'm sure you guys feel the same. All right, there's more to this though. So with this increase in blood volume, the body is making more blood products. They are increasing the number of red blood cells, but in general, the increase in red cell mass does not increase as much as the volume. Okay, so they're increasing blood volume, the body's making more red blood cells, but the volume greatly exceeds the increase in red blood cells. So when a woman is pregnant, it's very common to have what's called dilutional anemia. Basically, she doesn't have less red blood cells. In fact, she probably has more, but there's so much volume. And since hemoglobin is measured as a grams per deciliter, there is a drop in the hemoglobin measurement. It's typical to see decreases of like 1 to 2 grams per deciliter. This is a hemoglobin measurement. Oh, that's so messy, hemoglobin. Why I brought this up right now is not so much that has really any impact in their exercise performance, but this dilutional anemia does dilute some of the other blood products, like proteins in the blood. So because there's such a high increase in volume, there is a reduction in oncotic pressure. So if we come back up to our Starling's forces, the blood volume itself is increasing the hydrostatic pressure, but the high amount of liquid without a substantial increase in protein is actually lowering the oncotic pressure, which even further supports filtration of fluid out of the blood vessels. Where is the greatest impact that you'll see this edema? Well, where gravity is pulling down on the fluid and exaggerating that hydrostatic pressure, which is why swelling in your feet is so common. Women can get a lot of swelling in their hands. A lot of women suffer from carpal tunnel syndrome during their pregnancy because of the edema in their hands and wrists that take up that space in that carpal tunnel. But kind of keeping in mind what's going on with the edema, avoid motionless standing. If you can, using the skeletal muscle pump to keep blood moving through the system, that will help reduce edema. But this is something that is to be expected in the third trimester, and it is related to that increase in blood volume. Okay, so we said that there can be 40 to 50% increase in cardiac output that is driven by both an increase in heart rate and an increase in stroke volume because of this extra amount of blood being pumped through the system. What is the impact on blood pressure? Now, it says in your notes the answer to this question, so it's not a very good cliffhanger, but there is no significant change in blood pressure during pregnancy. How is that possible? Higher heart rate, higher blood volume, higher cardiac output. How do we measure blood pressure as mean arterial pressure is cardiac output times total peripheral resistance. And we know cardiac output is going up by 40 to 50%. So if there is no change in mean arterial pressure, what must be happening to total peripheral resistance? There must be a significant drop in total peripheral resistance. So in your notes it says, how is that possible? How is this possible that we're dropping TPRNF? And one of the big factors is progesterone. Progesterone is sometimes called the great relaxer, and it relaxes smooth muscle. So if you decrease the tone of your vascular smooth muscle, that causes vasodilation. And you can see, this is weeks of gestation on the x-axis here, that as you get into the later weeks of pregnancy, you get more and more and more of the great relaxer, relaxing all of the vascular all the smooth muscle in the body, and smooth muscle is the muscle of our blood vessels. So if you relate this back to that edema piece, if you add in vasodilation, this would only exacerbate the edema, right? Because you're having even more volume that's accumulating in these blood vessels. So that's an important piece that goes into the edema, is the loss of tone of the blood vessels. So during pregnancy, while there is increased activity of the cardiovascular system through an increased cardiac output, the cardiac output is countered by the drop in total peripheral resistance, so we don't see huge changes in blood pressure during pregnancy. But obviously, the blood vessels are not the only place that has smooth muscle. So, this significant elevation in progesterone as you progress through your pregnancy affects other systems as well. And a really big one, this is one of my favorite pictures, maybe in the semester, is our intestines are lined with smooth muscle that gives us our peristalsis and helps move things through our GI tract. So when progesterone is high, we see decreased GI motility. So one of the negative effects during pregnancy is constipation is extremely common, which is an important thing to talk about because exercise helps with GI motility. GI helps to move things. I feel like I just said GI. Let me just start that sentence over. Exercise helps to move things through our GI system. So that can be another added benefit if someone is dealing with constipation. And I don't have this listed in your notes, but we actually talked about it in PathoPhys. The lower esophageal sphincter also has smooth muscle in it, and that is relaxed during pregnancy. So heartburn is extremely common, right? Because the lower esophageal sphincter keeps our acidic stomach content separated from our esophagus. So during pregnancy, there's less tone of the lower esophageal sphincter, which means there's more opportunity for stomach contents to move up. Not to mention the fact that there is the weight of the baby that increases the pressure and helps to push things up. So if you have a patient who's suffering from a lot of heartburn, you want to avoid the supine position during therapy if possible, or any head down positioning, because this might really exacerbate the heartburn. All right, other effects of the smooth muscle relaxation is the respiratory tract. It actually causes a bronchodilation, so it's easier to get air in and out via the upper airways. But this little bugger down here, sitting right below your diaphragm, is going to cause some other issues as it relates to the respiratory system. So I'm going to leave off here so that we can break the lectures up before we start talking specifically about the respiratory system.